Good morning, everyone, and welcome to session 2. So for those of you that are joining the primary care stream sessions just now, my name is Claire Dagley and I'm Regional Senior Manager at Western Victoria Primary Health Network. I will be your facilitator for the day and I would like to welcome you all to this session. Our second session today is Advanced Care Planning, Goals of Care with Associate Professor Charlie Corke. We would like to thank Hospice for sponsoring this session. And remember, you can pop over to the Sponsors Lounge on the main landing page for this conference via today's online platform and browse through all the individual sponsors pages that are listed there. So as you'll see on screen, we've got health pathways information listed for you. The health pathways that are relevant to this session are what you see on the screen. Health Pathways is an online platform that is designed to support primary care clinicians in the assessment, management and referral of the patients according to best evidence and in consideration of the local context. So before I introduce our second speaker, Associate Professor Charlie Corke, I will just quickly cover off some housekeeping for those that have just joined into the program now. So during the session, if you do have questions for Associate Professor Charlie Corke, please type your questions into the live Q&A and you'll see the button for that on the bottom of your screen. And if you do have questions, then they will be things that we will present to Charlie at the end of the presentation. For any general comments, please use the discussion forum and you'll see the button for that on the bottom of your screen as well. So I'd now like to welcome Associate Professor Charlie Corke. Charlie is one of Australia's leading intensive care specialists and immediate past president of the College of Intensive Care of Australia and New Zealand. Charlie is Regional Clinical Lead for the Advanced Care Planning Program and is the originator of the My Values approach to advanced care planning, which is myvalues.org.au. He is author of Letting Go, a book that explains why planning is so important. He lectures widely on medical communication and end-of-life care decision-making and is a strong advocate for patient-centred care, as well as being Vice Chair of the Victorian Voluntary Assisted Dying Review Board. I'd like to now hand over for Charlie for his presentation.
Well, thank you very much for having me today. I hope you can all hear me. Advanced care planning, I think, is a very important part of medicine that is under-recognised and poorly done, but is a very important thing. Our issue is that our medical approach is survival at all costs, whatever it takes, however long it takes, and whatever the outcome. But patients see it a little differently, and patient control involves conditional consent. There are some things we'll consent to, but some things we won't consent to. We have limits to the amount of misery that we want to suffer. We can all think about unacceptable experiences that we wouldn't want to go through and wouldn't accept going through. And there are unacceptable outcomes. They're different for different people, and that's why it's interesting, but they're there. Most of us have got something that we won't accept. The study that we looked at with the University of Technology in Sydney, the Centre for the Study of Choice. So this is experts who look at how people make decisions and make choices in their lives, showed that the attitude to prolonged life support across a wide selection of Australian population showed that most people have limits. 61% had limits and 32% were sort of worried about it. They weren't actually prepared to implement their worries, but they worried about it, but sort of went felt they had to go on with it. And 7% had an attitude of whatever it takes, which is interesting because this 7% you'll see is fairly consistent, but they're a minority. When we look at older people, what happens is that as patients become older is that sort of worried but accepting group disappear, and they don't become whatever it takes people. They join the people with limits. But remember that 7% are still there, which I think is really interesting. They're always there. And we need to recognize them because they want a different sort of care to everybody else. And they're really into the everything, try everything. And we see them and we recognize them in healthcare. And if we're looking towards a patient-centered care, then we need to recognize these people. But we mustn't assume that the other 93% are those 7%. When we looked at the things that really people bothered about, if you look across this table here, maintaining dignity, avoiding pain and suffering, remaining independent, they were vitally important things, or very important. On the other hand, living as long as possible was a bit odd, and people are generally neutral about it. And what we find is that, of course, living as long as possible is something we'd like to do, providing we can have those other things, providing dignity, avoiding suffering, and remaining independent or avoiding becoming dependent are there. So if we only ever talk about living as long as possible, we're not going to pick up on those other things. Those other things are things that we need to recognize. And when we asked this, when we looked at it, we thought, well, yes, maybe people have those things, but perhaps they don't want to tell their doctor that those things are important to them. They just want their doctor to get them to live as long as possible. But we said the second part of the question was, which one of those things do you want your doctor to make the number one priority? And living as long as possible didn't feature greatly. So those other things are really, really important. So we have to talk about them. We did a study where we looked at oncology, and living as long as possible does feature a bit more in oncology, as you'd expect, because that's what people talk about all the time. But avoiding pain and suffering trumps living as long as possible. So talking about what's acceptable is still important. So what do we fear about these things? We found that in dignity, pain and suffering, and dependence or independence are important. What are the things that come up in conversation? Well, in dignity, it's the main things we hear around: incontinence, the use of nappies, needing to be fed, tracheostomy, and particularly dementia. Suffering, isolation, pain, illness, unpleasant interventions, being poked at and fiddled with. Dependency, nursing home, becoming a burden, being a burden to your family, loss of autonomy, and hospitalization. So there are a lot of features here that we can explore with patients. Now, people do find it difficult to bring these subjects up. And I think that a good introduction, a way of saying something that doesn't cause offense, is very important. And as thinking about this and having done it for a long time, I came up with this little approach. WOW. So it's worried, open, and wonder. So worry. When you say you're worried about something to a patient, you're not obliged to present an exclusively positive outlook. But the fact that you're worried about something is not that offensive. Just sharing your worries enables events to be highlighted without causing offense. That, what if you had another stroke? I'm worried that you might. You've had one thing that happened. You had one admission to hospital. I'm worried you might have more. It can be presented in general terms as well. You can worry. Other patients are telling me that they're worried about what may happen as their health fails. Is that something you ever think about? So you can package worry in quite easy ways. Sometimes when you mention your worries, you get back an answer that they're just hoping for the best. And I don't think hoping for the best is a plan. But there's a simple response to that, which is, I really hope for that too, but it's always a good idea to plan just in case it doesn't turn out that way. And as soon as you say that, patients will generally accept that they have these hopes, but they're sort of a bit unrealistic, and it doesn't hurt to think outside that. But you're not telling them that they have to give up their hope. They can have their hope. They can hope for anything, but they can plan at the same time. I put down the bottom here, what makes your life worth living, because that's what you're supposed to say. And as far as I'm concerned, that opening a conversation with that really doesn't seem to work very well. It seems to make patients feel very uncomfortable and confused, and they tend to clam up. So I'm not suggesting that that's what you should use. We can talk about that later, though. Open then is once you've said it, you then have to be open to listen and use open questions just to listen to how the patient responds and what they do. So how do they respond? Are they receptive? Are they hesitant? Are they resistant? And you take it from there. Paraphrase whatever they say back to them never gets you into trouble. If they said it and you say it back to them, it's not likely to get you into trouble at all. And encourage them to keep talking. And the main way to encourage someone to keep talking is by you not talking. Just be quiet and let people ramble on, whatever they're talking about. They'll get there in the end. And then wondering. So frame your proposals as a wondering. I'm wondering if you would want us to not resuscitate you if that happened. I'm wondering if you wouldn't want to go back to hospital if the same thing happened again. I'm wondering if you'd rather die than go into a nursing home. And when you wonder about something, it's very easy for the patient to reject what you're saying because you're just wondering it. You're just beginning to think about it and they can put you right. Or you can retract it. Well, I was just wondering, but I wasn't saying you had to do that. I was just sort of putting it up as an idea. So it's very, very easy to get out of. So I find those are really easy things to do. The big problem with traditional advanced care planning is that the average consultation takes an hour, about an hour. So with our advanced care planning clinic, that's the average time it takes. And some patients need several repeat 1 hours. For patients, there's a lot of confusion and ambivalence. They go backwards and forwards. They make a decision, then they go back on it. They're very all over the place. It takes skill and experience to do it. So it's not something, this thing about, just read the book or read the pamphlet and do it. You can't. It's complicated and it's time consuming. GPs are really not going to do this. I think that this needs to be done at the general practice, but it won't be done by GPs. So it's really important to have a system, and it's you. So how can you make it easy for yourself? Well, recognizing this 1 hour thing and the fact that what we found in our advanced care planning clinic, it was retired nurses came, they knew exactly what they didn't want and they were able to write it down and talk about it pretty easily, but everybody else found it very difficult. So as part of helping patients understand what they think, I had some money and made this My Values website. And the point about it is to try and help patients on their own work through the issues a bit and then come a bit prepared. So it's easy to register. You only have to put your name and an email in and you're in it. That's it. And it's free and it's secure. They then get a chance to look at a couple of statements and a number of statements that are put at both ends of a spectrum. So here I'd certainly want doctors to try and save me if they thought there was any chance at all of a good outcome. And then I would not want treatment to try and save me if a poor outcome is likely. And obviously those two statements could apply to exactly the same disease. And it's about which way do you want me to go? If I think there's a 1% chance of survival, do you want me to go for that 1% because there's a 1% survival? Or do you want me to focus on the 99% chance of a poor outcome and leave you alone? And people can know, well, that one doesn't resonate me, so I'll do equal A and B. And then as they go through the questions, it builds up a profile of where they're at. And what I really want to know is whether that person that I'm asked, that's unconscious and ill in front of me, is someone who desperately wants me to treat them or desperately doesn't. And through answering these questions, we'll get to that. So we've got over 10,000 users of this at the moment. Certainly the advanced care planning clinics now using it because they're overwhelmed, and it's a way of helping patients get there before they come in. And these are some of the sort of answers we get. So I'd rather be allowed to die than survive to go into a high-level nursing home. And so strongly agree. So most people are not that keen to go into a nursing home. But 15% are. There's no point in continuing to live without quality of life. Again, that's that 7% who disagree with that, but the majority of people agree with that. So quality, they want to talk about what quality means, and that leads us into talking about what quality means to them. I'd accept high-level care in a nursing home if this became necessary. So this is the acceptance one. So there's 15% accepting it. And then when they get to the end, the views are, if they've given a number of answers that are all the same way, that becomes more strongly held views. And then there are more mildly held views. They can edit it. They can take that view out if you look at it and think, oh, no, it said I think that, but now I don't. Or they can add, you can see the green writing here. This green writing is what they've been able to add to it. So when you've added it, if you want to qualify it to make it even tougher or explain it or water it down a bit, people can. So they can personalize what comes out of this. And then this is a thing. Once they've done that, they can then sign it, electronically sign it, or they can revise it, or they can just delete it, throw it away. It doesn't. I've done it, but now I no longer want it. I don't like it. And then for Victorians, they can then use the answers that they've produced in this to populate the beginning of the values directive in the Advanced Care Directive for Adults under the Medical Treatment Planning Decisions Act of 2016. So that's the formal form. So they can begin and get their formal form half filled out before they've even started. So automatically they can just do that, and it does it for them. So we've got a beginning of the process for them without any intervention from health professionals, and then we've got them started and we can tidy it up with them, so it reduces the amount of work. One of the issues, of course, is that the major group of people where this is very important are those who are over 70 who aren't fabulous with computers. But there's a very simple solution to this, which is that they can ask a young relative or friend to do it with them, and it's informative for their young relative, and the young relative obviously scoots through the electronic issues without any problem at all. So it's a good way of bringing them together. So this is some of the advertising we've got for it. So we've got some of this. If you're interested in it, make your voice heard, make a plan that sticks. That's obviously a fridge magnet. Leave your mark. That's a bookmark. Because of this, it uses a minimum of clinic time. It's painless for staff, just encouraging patients to have a look at this and do it. It provides focus on the issues because they really haven't thought about what the issues are. People are very stuck on, would I want dialysis, or would I want ventilation, or do I want to be a vegetable? And none of this really helps to make a plan that's very helpful, and it just causes them issues about worrying about writing it down and upsets them. The process stimulates their thought, and often they say, I hadn't really thought about the issues, but now I have. It's helped me to think what I do, to understand how I think. It creates the report. It enables sharing with families as well, which is an important part because they need to get their family on side. So it's easy once you've done the plan to just send a link to family and get them to have a look at it and send a message that they endorse, whether they endorse it or want to talk about it. And it integrates with the Victorian plan. It's free and it's funded by DHS and run by Barwon Health. Of course, there are some patients who are very complicated and won't use the computer. And we have the Advanced Care Planning Clinic in Geelong, but patients obviously have to come to Geelong and make an appointment with the clinic. But that's what some of them want to do, and that's freely available to them. And certainly that plays a role. And there's the phone number for it. So I've got a number of tips for you. My first tip is that advanced care planning is best when it's started well in advance at a time when the patient's in good health. So this really conflicts with some of the arguments that you shouldn't do. And we hear from GPs all the time when patients talk about it and they say, oh, you're fit, you don't need to do it. And the idea that patients will do it when they're extremely ill at the end of their life is not is a delusion. The sicker people get, the more difficult this is to do. So really, this is something which I would like everybody to do as they get older. I mean, it's no reason why young people shouldn't do it. And one of the things I'd say to all of you is that as people who may health professionals who may be encouraging others to do it, the best thing you can do is to do your own. I mean, just do it, because I can guarantee you at the moment that if you come in with an absolutely catastrophic stroke with locked-in syndrome, I'm going to save you. So if you don't want to be saved, to be just able to move your eye and nothing else, then do a plan. I'm sure there are things that you wouldn't accept, and just write it down. And then if you've done that, firstly, you've got an insurance policy in case some utter catastrophe happens that will give permission to your family to step back and not insist on keeping you going in a situation that you'd utterly loathe. And secondly, it makes it much more convincing to patients if the thing you're asking them to do is something you've already done. There's nothing more convincing to patients than hearing that the person who's asking you to do it's already done their own. If you say, I want you to do this, but I wouldn't dream of it, it's not all that convincing. Tip 2. Trying to start, obviously, this is the second part of delaying things too late. This is delaying things much too late, and we're often trying to get decisions and discuss this stuff at a time when people are very ill, and the stress of it, fear of dying in a very threatening environment, and the ambulance standing there waiting to take them, and it's really difficult. Doubts about competency. Can someone who's hypotensive and hypoxic make good decisions? Or as their dementia is beginning to gallop, there's going to be lots of questions about their competency. If they're saying the same thing that they've been saying for years, that they said earlier on when they were well organized and well, then it's much more likely that it's consistent than if they're saying something if we never knew what they thought before. And a time pressured and coerced, what are we going to do with Mum? We've got to make a decision in the next half an hour about whether we're going to chopper her to Geelong or not. It's really there's a lot of coercion goes on, and disempowerment and fatigue. It's amazing how disempowered you become in hospital. And when you're sick, you just don't have that power to control things. And also, as people become older and sicker, the rest of the family don't let them make decisions. You lose your ability to be allowed to make decisions and be respected as you become older and sicker. So trying to plan in the middle of a crisis and trying to start this process up is not a good idea at all. And ideally, as I say, should reconfirm what's previously been explored and bring them up to date. And the other thing, but by doing that, means that each time you redo it, it's only a tweak. And there's this delusion that as people become sicker, they become much more tough and they want things that they didn't want before. Our experience, both in the advanced care planning clinic and in the intensive care, is that as people become sicker, they become tougher, and they're not as they go backwards, not the other way. If you coerce them, you can make them go the other way, but if you leave them and listen to them, people generally are pretty sensible about what they want and don't want. So starting early on and just allowing people to tweak it a bit is much better than doing nothing and trying to do it all at the end. My fourth tip is to set achievable expectations. The first one is that all you're wanting to do with your patient is to get them to think about the issues. And that's relatively easy because it's about giving them a My Values brochure and suggesting they do it and bring it in when they've done it. The second thing is that they talk to the family, and again, the My Values report gives them something to talk about to their family that focuses both them and their family on the right issues. appointing a decision maker is probably the simplest thing to do and is incredibly valuable. What it means is that a family member who's sane and sensible is identified, and the family members who are not sane and sensible are excluded. So this means that the and also that so the decision making will be uh, focused on the best decision maker. It won't be subverted by the worst one, and it won't rely on a family committee, which can be very complicated. I mean, some families work brilliantly together, but geez, a lot of them are quite dysfunctional. So one good decision maker is a really valuable thing. The other thing is an appointed decision maker has a lot more power than someone when there's no one been appointed. So just picking out a sensible decision maker is a really good thing. The next thing, they can write down their wishes. So we haven't written anything yet. We haven't got any directive yet, but then you can suggest to them that they write it down, and then it can be, they can write it down anywhere, or they can complete a Victorian advanced care plan, which has a values section and an instructional section. And the idea of that is that the values section says how I feel about things and just conveys that, whereas an instruction is much more firm, and it says I will not have something. Now, not many patients are that determined that they're prepared to say what they won't have. I will not, under any circumstances, have. Jehovah's Witnesses will say that about blood, but not many people are that determined. There are some who are determined. You will not resuscitate me under any circumstances if my heart stops. But if we try and push them into doing that, a lot won't do it. Whereas sharing your values, telling your family what's important to you and what outcomes you wouldn't want is a lot easier. So that's in the values section. And the final thing is to share it. It's important that this is shared widely. It's not something to do and stick in your solicitor's safe. This needs to be shared with the family, and preferably with the doctor as well. And the Victorian advanced care plan needs a signature from the doctor, which I'm pleased about, rather than getting a signature from the lawyer. So the lawyer just charge money and won't add anything. The doctor can add some insight and endorsement of the process, and then be aware if they're in a position of needing to send the patient into hospital or make choices for them. So, I mean, finally, the other thing is that the enduring power of attorney forms and the advanced care plan forms are available for free off the website, the Health Department website, and the Office of the Public Advocate website. And you can just print them off and give them to patients. So, my solicitor tried to charge me $500 for doing one, and it's outrageous. They don't have to do that, and they generally aren't. The plans that the lawyers do generally aren't very good. So I wouldn't suggest that you just send your patients to lawyers. And I just finished by saying I have done my advanced care plan. I have appointed my daughter here. This is my daughter. She runs a wildlife park down in Apollo Bay, and she's pretty tough with the animals when they're not good. And she's a good decision maker and a clear decision maker. I've appointed her to be my enduring power of attorney rather than my wife, because I think my wife would keep me going far longer than I wish, and would worry about making a tough decision to stop. I've also got two other younger daughters who are much more creative. They're not great decision makers. And when I talked to them about it, when I was appointing Lizzie as my enduring power of attorney, they agreed that they'd find it incredibly difficult to make the decision. They said, well, she's hard and harsh like you, which I took to be a compliment. And so that's what I've done. And again, I can tell, suggest that to my patients, that that's what I've done. I have an insurance policy. I feel quite confident having this in place. And she's very clear about what I want and don't want, both because we've had conversations about it, and because I've written things down. I've done my values, and I've exported it into the Victorian form. So I've done all those things, and I feel reassured by that, which I think is the reassurance that most patients want. I'd finally just finish by saying that I wrote a piece for The Conversation recently, because where people are talking about outcomes, we found that isn't particularly helpful, because when you see someone who's very sick and they say that they don't want to be saved if they're going to be worse than they are at the moment, or if they're going to have to go to a nursing home, or if they're going to be in a vegetative state, none of that helps, because at the time you don't know what the outcome will be. You cannot be certain when you see someone very sick what the outcome will be. Do not resuscitate me if I will not make a full recovery. Well, I don't know at the time. So what is a more effective thing is if they talk about risk. If you think there's a substantial risk that I may have to go to a nursing home, that I may end up in a nursing home, if you think that it's more likely than not, if you think that if you're worried that I might, please don't do this, then you can interpret those things at the time, and they're much more effective. So you do have to think, will this work for my doctor and my family in a crisis? And if it needs that's what you're doing the planning for, and it's important to get that right, so that because I do see lots of doctors who look at them and say, well, they're not worth the paper they're written on. I can't interpret them. They're all vague. So it's important to write them in a way that they'll work. So I've left a bit of time for questions, and I'm happy to answer them.
Thanks so much, Charlie, for your presentation. And we definitely have some questions from the audience for you. So I'll just start off with a question from Tom. So he asks, what training is available for practice nurses to upskill in this process to make advanced care planning more accessible in general practice?
Well, I think that's a fabulous question, and I don't think there's anything, which I think perhaps is a very good take-home message. I'd be delighted to be involved in something, and that's something perhaps the PHN could take on. It's not, this has been a really odd implementation across the country. It's been taken up better in Victoria over the years, but recently the Victorian Health Department has lost interest, with VAD, I'm afraid, has taken over their interest, and this hasn't been supported as much over the last 4 or 5 years as it was at the beginning. There's been great, this idea that people are sitting there waiting for jobs to do, and if you just ask them to do it, they'll do it. Funding has been a major problem because I gather that the over 70s review is already used up. There's been suggestion that could be used for advanced care planning in general practice, but it just hasn't really happened. We did do a project where we sent out our facilitators to general practices in Geelong, but that funding has run out and no one picked up on it, although the number of patients was phenomenal and the number of patients who came to it was phenomenal, and the transfer to actual successful filling out of meaningful forms was really good. But it didn't, the funding, like many good projects, the funding runs out and then it stops. So I think it's a really important thing. I see this as something where, that we've got an aging population, we've got a burgeoning health, opportunities of things we can do, but probably many of them are things we shouldn't do to elderly dying patients because they don't want it. Why on earth are we spending masses of money on things that people don't want? It's silly.
So it sounds like there's definitely more to be done in that space, and some opportunities to be doing more than what's happening at the moment, for sure. So next question we've got is from Margaret. So Margaret said, primary healthcare nurses are well placed to initiate these discussions during health assessment or care planning consults. And the general practice setting is ideally placed as there is an existing level of trust and rapport with their patients. The lack of an MBS item number to support this activity is perceived as a barrier for business owners. And so do you know if there is any government movement in this space?
Look, there's been repeated requests to government. Government are terrified of any new item number for anything, and it keeps being put up to them, and they keep rejecting it. Of course, I totally agree with Margaret's points. Of course, general practice is a fabulous place to do it, and practice nurses would be ideal. It's obvious.
Yeah, for sure. So that sounds like another thing that needs continued advocacy for. Absolutely. Sonia has asked, is there any chance of participants being presented with a copy of your slides, Charlie?
Yes, there's every chance. You're very, very welcome to them. I'll upload them to the PHN, and definitely I'd be delighted for you to have them.
Fabulous. Thank you. We'll pass on information to participants about sending those around. Just want to make sure I'm not missing any questions. So Penelope said, in these discussions, we talk about all the medical options to keep people alive, but don't often talk about allowing natural death. Do you think this is useful, or are there other phrases or words that you have found useful?
Yes, I think it is important to get away from just talking about the treatment. So you could have a treatment, so that classic statement, we could operate on you and save your life, or you could just die. Or do you just say, we could operate and save your life, would you like me to? And you don't talk about anything else. So it's very important to talk about the options. What I do is to talk about the possibility of making dying worse. There's a risk with all of the technology we have. We can use it, and sometimes we use it and it's fabulous, and sometimes we use it and it isn't. And I ask patients whether they have any experience of that, and almost everyone can come up with an example of some relative who's been dragged through medicine for ages and or ended up in a nursing home totally demented when they'd said they'd never ever wanted to go there. So you can hear that from patients. So it's about using tech. People can get the idea that good things can be used and turn out badly. If you unwisely use even the powerful thing, if you unwisely use powerful things, you can end up in a bad place. So they're words that I use.
It sounds like that's definitely helpful. Thank you. Some other questions we've got. I've got a comment. So Ingrid has said, she's one of our practice facilitators, that the advanced project offers training for practice nurses and practice managers as well as GPs. So she's added the link to the Q&A box for anybody who's interested in having a look at that. We've also got a question from Anonymous, who said, if a patient has done an advanced care directive, do they still need an enduring power of attorney for medical treatment, or is the advanced care directive sufficient?
No, they need both. It's interesting. So Queensland have their advanced care directive, or their legislation really talks about the legal document being the only thing, and the relatives have no role, which I think is silly, because relatives think they've got a big role. In Victoria, we do it the other way round, in that the decision maker, the family decision maker, or the person, it may not be the family, but the decision maker is the important, but the surrogate decision maker is the important one, and the document is really informing them and helping them make the right decision and the best decision for somebody. And if they write an instructional directive, then that trumps it. They cannot, if you've written an instruction, your decision maker is unable to make the opposite decision. But I mean, a lot of these things are a bit vague. And certainly, so it's really, really important to have that decision maker done, and people don't find that particularly difficult to do. So I would certainly suggest that everybody should have. I think it's important. The most important thing is to have the appointed decision maker, and you only need 2 witnesses. You don't need a doctor to sign that. It's just 2 witnesses on one side of A4 paper on that printed out thing. It's a very simple form. So I'd recommend that, and definitely having, for me as a receiver of these things, having an appointed sensible decision maker, it takes away about half the problem before you start.
Sounds like that's a very important decision to make about who takes on that role, for sure. And it was great to have your example of your own experience with that process too. So thanks for sharing that. So just having a look through, because we've had a few more questions added to the chat here. So we've had Tanya ask, she said, I am a border resident. Is there an equivalent New South Wales, I'm assuming Advanced Care Directive that you've mentioned there, Tanya?
They're all a bit different in each state, but fundamentally, there's a lot of talk about the form is so important and we've got to have a better legal form and whatever. But in practice, the thing that actually works is when somebody comes in and they've been consistent about what they've been asking, what they're worried about and don't want, and their family and their doctor confirm that, and that you put up a proposal. Do you think it would be the right thing? Would it be reasonable if we made this decision? And they all go, yes, that's exactly the decision they'd make. So it's about consent. You don't have consent to do it. And if the family say they haven't given consent, and the doctor confirms it, that's really, really valuable. So the form isn't as, people talk about legal forms, but people don't like writing legal forms in a way that takes away their opportunity to, everyone's the same. What we want great medicine to save us and to be magic at the end, and we don't want rubbish stuff. So we don't want to take away all our chance of having, being saved in a really impressive way, but we don't want bad stuff. So you can't take away. People ask this resuscitation question all the time, and most people, I think the sensible answer to the resuscitation question, look, is of course you can resuscitate me if you can bring me back in one shock and I'm back and I'm just the same as I am now. Of course you can do it. But if, of course, after half an hour, if you do it and I end up massively neurologically damaged, I don't want it. And it's so we get all this thing about I never want to be intubated, and then patients come into hospital and they need an operation, obviously a laparotomy, and they're going to need intubation and ventilation for the laparotomy, and anaesthetists get all very upset. Well, they don't. Is that what they mean? What do you actually mean when you say you don't want to be resuscitated? And in my book Letting Go, I talk about a patient that I looked after who had a not for resuscitation order, and I hadn't done it with her. She came in with a large inferior infarct, and while I was talking to, or she was talking to me, she rolled up her eyes and had an arrest, and I shocked her. And she continued the same. She was telling me about how she would have wouldn't have her gardening stockings on if she'd known she was going to come into hospital. She'd have dressed better, and when after I'd shocked her, she continued the conversation. So she didn't even hardly even knew it had happened. But then she was very cross with me because she said that she was not for resuscitation and I'd resuscitated her. And I said to her, well, I thought that your resuscitation request related to outcome. And she said, well, it did really, but I don't like not being listened to. And we had a conversation about it, but it was about and she did forgive me, but it was about understanding what her goals were, which is what all this is about, because the title of this, sensibly goals of care, it is all about goals of care, establishing goals of care for patients in a plan that can help you to achieve that for patients when the time comes.
Absolutely. So we've just got a few sort of comments as well. So Carolyn has just said that her current concern is misunderstanding around medical power of attorneys, thinking they're allowed to make decisions even when the patient is still deemed competent. And I feel that it's very important for the patient and the medical power of attorney to understand at the time of completion of documents. So is there anything you wanted to sort of comment around that, Charlie?
Well, yes, yeah, of course, that's the point, that it's all about when you're not competent. And I take it the other way. A lot of patients think they'll always be competent. I'll always be able to make my own decisions, so I don't need someone else to do it. And they need to be informed that at that crisis point, almost most people at the point where you need to make these big and important decisions, towards the end, patients are not conscious and not able to make their own decisions. The other point I'd make is, perhaps taking it the opposite way, is that I do think that we don't look at these plans enough when patients come into hospital or start to get sick, because the best time to revise them and think about them is when someone starts to get sick but can still give you input into them. So if you have a look at somebody's plan, and it doesn't sort of make sense, there's an opportunity to talk to them about it. Whereas if you leave it in the file and you don't look at it until they become unconscious, and then you go, oh, I can't understand this, that's a bit silly, really, because they were conscious yesterday and you could have talked to them. So I think they should be got out before patients become incompetent, if you can. And they should be talked about with the patient and their surrogates, because it's a great time. So that's that bit about not leaving it till you don't leave starting the plan till the crisis, but in a crisis you get the plan out and work it through and see if it's still valid and what it means. And I do get frustrated when patients have been in hospital for a week and then have become unconscious, and then someone gets out the plan and then queries it. Why would you do that?
Absolutely. Yeah. So that definitely just reinforces the importance that it's not a one-off conversation. It's really an ongoing conversation that needs to be had at different time points.
Absolutely. And of course, people can change their mind. We have to accept that people can and will change their mind, and that's fine.
Absolutely. I think everyone's entitled to change their minds. So that's very good. So we might wrap it up there because we're almost out of time for the session. But thank you so much, Charlie, for your time and your insights. That was a really wonderful presentation. I know all the attendees have really valued it, and thank you very much. Now for the participants, just to remind you that there is an in-session evaluation which should pop up onto your screen now, now we're actually leading into our lunch break. So now we've got a break from 11:50 through to 12:10. So please take this time to grab some lunch or stretch your legs. And if you do have a bit of time while you're waiting for the next sort of sessions to start, you can go and have a look at the sponsors lounge, as well as the Westvic PHN resource section, which is on the main landing page. Please make sure you're back and ready on time for the commencement of the next session at 12:10. And to exit this session, please just click on the back to timeline button that you'll see at the top left-hand side of your page at the moment. Enjoy your break, everyone, and we'll see you back here after lunch.